I'm Alison, like you said, I'm from the Queensland Children's Hospital. I'm the CNC and infection control there. I'd like to say thank you very much for having me today because I feel very honoured to be here, to be on the line of people talking. When I was thinking about joining up for the Genomics, I asked the girls in my team, which was Trish and Melinda, what would you like me to do? Because I feel like I hadn't contributed enough. I was thinking I would get them to do leaflets or some kind of educational activity, and they said, would you like to present? And it really wasn't what I was hoping for. So here I am presenting. I also do talk fast like I'm an auctioneer, so please tell me to slow down if I talk too fast. If you have any questions, please stop me, put your hand up. I usually do this talk to maybe like a grad talk to nurses. They usually glaze their eyes over and look at their phones when we talk about infection control, but I have a bit of a more captive audience today. Oop, just enter, is it?
The arrows along.
Okay, so we just thought we'd do a quick little activity. And if you're an infection control nurse, you could probably answer this in your sleep. But what is infection prevention and control? Anybody? Nothing. Belinda.
Hand hygiene, Nazis perhaps?
Yes. I haven't won the Christmas party decoration poopers because apparently we're the ones who tell everyone to take their Christmas decorations down. Anything? Anybody else? Nothing? What was that, sorry? Beautiful. Anything else?
It's putting in processes and procedures in place to prevent the transmission of infection within a healthcare facility to protect the patients and the staff.
Yes, I can sit down now. Thank you. Very perfect. Oh, arrow. Apologies. And what does an infection practitioner nurse do?
Not a whole lot. We just sit there and tell people.
That's what it feels like. Yes. Anybody else?
It's fun. No.
Yes. Christmas decorations? No.
Wash your hands, take your false nails off, take your rings off, take your watches off.
No Fitbits.
Take your dermal implants out.
Mm-hmm. No.
Audit and more audit.
Yes. And no, you cannot wear your Fitbit today.
I would say that when patients come to hospital, they have an expectation that the disease that they present will be treated. And they also have a very reasonable expectation around additional diseases or complications. The most common cause of additional complication by far is acquiring infection in hospital. And every year at Royal Brisbane and hospitals around Queensland, people die from infections that they acquire in hospital, whilst that was never their original problem. This is a critical thing that we have to do really, really well. The community expectation for how right we get this is 100%. And it's, I think, one of the most important things that we do as a profession and as a HHS or as a system, really. Protecting our patients and making sure we don't do stuff that they didn't already have in the first place.
Yeah, 100%. People kind of think we don't do too much, I'm pretty sure. It's QCH. We sit in the actual basement of the hospital next to the car park, and I'm pretty sure they really don't think we do anything down there. But like you said, very important, and we do help prevent a lot of infections and also then do surveillance to try and prevent further infections if we see problems. So just a quick overview of infection control. So different HHSs obviously will look different infection control, and in this room there would be lots of different nurses from different HHSs. Of myself at Children's Health Queensland, obviously, we would have one CNC and 2 full-time CNs, where if you went to the PA, you have 3
CNCs and 4 CNs,
yep.
Infection control scientists.
Yep. So I know at the MARTA, they've got a scientist as well, and a CNC about 5 CNs, and then say at Torres Strait would have 1 CNC for the whole of Torres Strait. So it does vary for your geographical size and location. Also your patients. So if you worked at the MARTA, for example, they have MARTA Mothers, the highest maternity hospital in Brisbane, or the state actually, and so they're going to be very different, say, Queensland Children's or to the PA who doesn't do children at all. So that really does make your day very different. Epidemiology, so what outbreaks are happening in the community at that time. So currently we all know we have measles in Metro South, so that's making a lot of our making our days busy. Other things that we do is clinical governance, and we have an increasing scope in infection prevention and control. So this is just a list of some of the things we cover on a daily basis, and some days you'll do all of them, some days you might do one or whatever. So clinical governance, policies and procedures. We are custodians of the infection control management plan. We do risk management, our favourite, accreditation, education, and everyone else's favourite in the hospital, the hand hygiene coordinators and educators of the auditors. We look at ANTT, and like I said before, we audit, and hopefully we feedback and close the loop as well. So we look at workforce and patient screening and vaccination. So with the new VPD that came in from 2016, each HHS does something slightly differently, but that is part of our program now in infection control to make sure staff are immune to measles, mumps, rubella, hep B, varicella, and had the whooping cough vaccine. It's also a part of accreditation that we need to make sure consumers are engaged. So that's one of our accreditation criteria, so we do have to have some consumer engagement. We look at surveillance, so we all look at all your BSIs, your surgical sites, occupational exposures, MROs. We do outbreak management, AMS guidelines. Personally, at Children's Health Queensland, we don't do the sterilisation, but we do partake in their board and we give them advice. I'm not sure what other infection control teams do, but that's what we do at Children's Health Queensland. We monitor all the construction going around, all the maintenance going around the hospital, and then we give clearance if that's allowed to proceed and what they need to do to prevent infection. We also do some research, so we do a lot of research at Children's Health Queensland, and we actually have research nurses that align with infection control and infectious diseases. Obviously staff health. We do management of blood and body fluid exposures, and we are the holders of the meaning, or secret meaning of life. So surveillance is probably the biggest part. I would say probably the most important part of our day. Like Kristen was saying, we really need to have our eyes and ears open all the time to pick up things that are happening in the hospital. So surgical site surveillance, occupational exposures, bloodstream infections. We need to look at things like tuberculosis, norovirus, influenza. And this will vary between hospital to hospital. So in CHQ and the paediatric population, we care about every single respiratory virus that walks through that door. If you went to an adult hospital, they probably don't care if you've got RSV, but we do at the Children's Hospital because it can cause significant mortality and morbidity to small babies, for example. We also are very strict on the children's because we have a very high population who are under 18 months of age who haven't had all the vaccines, so we need to make sure all our staff are up to date, for example. And then we're also looking out for new MROs. So Candida auris is one that's always on our radar to keep an eye out for, especially international transfers, and with CRE is another one we look for. So MRO surveillance is another thing we routinely do in infection control. Not every HHS, like I said, may be different. So I do know routinely in pretty much every HHS, ICU patients, whether you're NICU, PICU or adults ICU, would always get screened on a weekly basis. If I'm wrong, please yell out. I'm happy to learn something new. And also, each HHS is different, but a lot of them would do also burns patients, CFs, and oncology patients, solid organ transplants every week as well. We also do, in our HHS, long-term patients once a month. So if you're in greater than 30 days, you get a swab once a month as well. Into hospital transfers and overseas travellers. So we would only do in our HHS if you've been in hospital overseas, but I think you do if they've just travelled to certain areas. Is that right?
Depends.
Yeah. And then surveillance by exception, so if you have something weird and wonderful. So we have a lovely system called Multipack, and I'll just go to this slide. This is what it looks like. For those who are in infection control can say, it's a fantastic system. I mean, every system has its flaws, but it really is quite a good system, and it really gives us up-to-date information, what's happening on the floor in the hospital. It can also print off these wonderful reports for us. It can do many reports. It's just one example. So I can put in, say, January to January, and it can say, I want these particular organs. So this one is looking at MROs, for example, and it can tell me every MRO in the hospital in that time that we've had, for example. So I would call this a hospital CN, but I think other HHS will call them something different. So this would be something every day that somebody would look at on a day-to-day basis that's really frontline running the hospital. So we have to check OzLab, we have to look at Multipack, allocate patients, isolate patients, go to patient flow meetings, check environmental swabs, make sure patients are paced correctly, try and clear patients, and communicate with NUMS and bed managers. So that list is basically all of that by 9 o'clock and then redo it all again for the rest of the day. So it goes around because patients come, patients go, new patients turn up TD, patient gets discharged. Then we get a new MRO that's been sitting in a 4-bedded bay somewhere, and etc. The list goes on. Or we get a patient, oh, hang on, that patient was in Singapore hospital for a week and we never knew. So then we have to then start all over again. So other things we do is we update databases, we do environmental surveillance, so we do water testing for Legionella, we do environmental for kitchen, food services, etc. Chart marking is not, we don't do that, but we do use IEMA and put updates for things in IEMA, so depending what technology you've got at your hospital. And we continue to check alerts and we liaise with ward staff. And as you know, we get many phone calls. So how do we know when things have gone pear-shaped? You get one of your many phone calls, usually. And what does this mean for patients and patient flow? So it can, what we make on a daily basis can really have a big impact decision on the rest of the hospital. A good example would be something like a norovirus outbreak we had on when I say recently, maybe 18 months ago in cardiac, and that really has an impact. I had to close that whole cardiac ward. Now that really has an impact for a patient sitting at home that needs to have urgent cardiac surgery and then can't get a bed in ICU because I can't move the cardiac patient from ICU into the cardiac ward. So what decisions we make on a daily basis can really have impact to the whole hospital and to patients at every level. And how does genomics help? So I just thought, just in finishing, I just have a very cute little story of how genomics has helped us. It's nothing very exciting like the big huge outbreaks they have at the PA and Rob Prison. Not that I'm going to complain. Definitely not going to complain because I do not want a huge outbreak of an MRO. Norovirus is enough for me. Okay, so we had a patient in Piku, as you can see the first bed there, and he was the index patient. He came from another hospital. I think he came from Darwin Hospital, and he sat in bed 23. It's really just to give you the flow of the story. Then he left that bed, and we ordered an incorrect clean. So the Piku staff ordered an incorrect clean on that bed, so we have different levels of cleaning. The patient in that bed had an ESBL, and somebody ordered a clean for a respiratory virus. So one is obviously going to just be a detergent clean, which is not going to kill the MRO. Then that patient left, the wrong clean was ordered. Patient B came into that bed, was there for only 24 hours. They had a swab because they were in ICU, but that was negative because they had just turned up to ICU. Then that patient went to the ward 10B and sat in a 4-bedded bay. That's fine, we didn't think he had anything. Then we did a swab on him after he'd been in that 4-bedded bay for a while, and then he came back with ESBL. Then we said, you need to isolate that patient, but he was too unwell. He needed to be in that 4-bedded bay because it was close obs in cardiac ward. So we said, you have to put that patient under strict infection control, like isolation. Then a parent in that room put a complaint in saying the nurses plus the parent of that child and doctors weren't washing their hands properly. Then we swabbed another patient in that room and they also had ESBL, so we thought this looks a bit suspicious. So then we emailed and got Patrick, I think it might have been, and got genomic testing, and we now know that all of these patients acquired ESBL from that one patient in Piku because an incorrect clean was ordered. So this is a very good example why infection control is so important in a hospital. I know it's only little, but it is really good, and you can't deny where the fault has gone wrong. And I say it makes epidemiology much easier than it probably ever was before, like hypothesising, etc., when you've got the exact information there. And that's all I have for you. Any questions? Go ahead. Yeah, at the end. Thanks, guys.
As someone who talks pretty fast myself, you've talked very fast, which is great. It's efficient. It's more efficient. So we actually, because we're ahead of schedule, we're going to take some questions now for the first two talks, and then we'll do Patrick's talk afterwards. Just one thing, the issue of Semmelweis came up. I think Paul mentioned Semmelweis. Everyone know what Semmelweis was famous for?
Finding that he initially found from after his mentor died after getting a Nikon finger doing an autopsy that's been, I wasn't aware of microbials, it was basically dead flesh is what he called it. And then he came up with the idea, he's tested various waters, and he started chlorinated water was best to wash your hands in. And washing hands is a great idea between doing an autopsy and then going examining a person's mother.
Yeah, right. So Semmelweis actually isn't famous for cleaning hands in general. I came up with the idea of cleaning one's hands with chlorinated lime, which actually killed the bacteria. And how did Semmelweis end up? Depressed, committed suicide, rejected by his peers as a charlatan or outlier and much hated. And then died of sepsis eventually, I think, yeah.
In a cycle.
Yeah, because of his extreme hatred directed to him by his peers and colleagues. I guess the other founding mother of infection control was Florence Nightingale, who I guess really pioneered the concept of surveillance in hospitals. That's what she's really, really famous for, as well as hospital corners on the beds I hear as well. But she's really famous for the idea of not just accepting what was happening in the unit, but monitoring it with surveillance and using that surveillance data to impact. So that's sort of where modern infection control started.
Pie charts.
Yeah, pie charts. That's right. Okay, so we'll see if there's any questions. I do have a chairperson's question to ask first. Just in the phylogenetic trees that you showed, Caitlin, I wondered, I don't know if you can even bring the slide up again, but I wondered what is the best way of presenting that visual data. So the phylogenetic trees are incredibly important in terms of visualising what's going on. I know I've got my own personal preference, but I'm very keen to see how you guys, what you think is the most useful way of presenting this data. This is very relevant for programs like the CatHi tool which tries to demonstrate these things.
So, that one?
What do you reckon? How those ones? That's super pretty. But how do you think it's best visualised? I guess the top one, yeah. I kind of like this one, I have to say, this one here, because it really gets to the core of, for an outbreak, maybe not for a large-scale monitoring, it kind of gets to the core of this is the patient of concern or the isolate of concern in the middle here, and it then spreads everything out from it. I kind of like that one, whereas maybe for larger population-based studies or so forth, the phylogenetic, more traditional phylogenetic tree is good. One thing I picked up on though is, that's just arbitrary though, is that right?
It is arbitrary, yeah. So I guess, and like you said, it's depending on the story. If you are talking about a transmission network and you're thinking about it like that, it kind of works to have it visualised that way. But if we're talking about a cluster in a tree, it sort of looks easier. I don't know, that's Brian.
No, that actually is a misconception. If you could go back to the previous bigger I had misunderstood that. I thought this actually indicates genetic difference. Would everyone get that now? There's a bit of a change for me today, is that this isolate could actually be much closer to the top ones as we think. It's just how it has to be.
It's just that branch length.
Yeah. That's really useful to know. Thank you. Okay, any questions?
Just on the representation, from my perspective personally, as a clinical person, something like this, vertical, is useful because if we want to add in the metadata about where the patient's been in time and space, like a Gantt chart or something like that, this is much easier. Yeah. It's the same with the CatHi thing. It looks cool, but it's much harder to think about. Because what we want to put against that is where the patients have been when. So that, to me, I find this a lot easier. Even if a network, yes, it's spread, not just in one direction.
I think the hope maybe with CatHi is that it might actually physically map to a map of your hospital or a map of a ward with beds, and you might actually have the isolate numbers on the beds and so forth. You can only do that with the dimension of time.
Yeah, with time it would be helpful, but without time, just a day of isolation, sometimes you're missing a lot of important information.
Yeah, I'm just going to come back to this again and again, but molecular genomics is only a tool, and what you saw from Alison's talk is really, it's just the information that goes in, but then there's this whole team that actually has to do something about it. And the cost of doing whole genome sequencing with no infection control is infinity dollars because there's no impact, so it has no value if you can do it without all of the amazing infection control work.
I would just say, as an outline using that you use that in typically requires that it's correctly included. It means that you use the bacterial strain, which is closely related, but not from your outbreak strains. So if you portray it through like that, people are going to think that it's included. So that might not be the actual correct structure that you're in this outbreak correctly. So generally, when the do like what we choose is what we do. And this would shoot the results more binary. Now you can do big binary where it takes halfway between the numbers branches, which would be probably a better way to represent that if it's not really popular.
So I may have the wrong impression, but the circular representation, it seems, is used more often for large population studies, and I presume that's because you can fit more in than you can only, sort of. If you're going sort of vertically, you'll run out of paper. So I've seen that. Is that an incorrect impression?
And you can add, like you're saying, you want that extra data along the side of it. With the circular one, you can add it around the edges.
Not in Excel.
Any other questions?
I have a question for you. Yeah. So you swap your high-risk patients.
Yes.
Have you considered residents from aged care facilities?
I don't see aged care patients in Children's House, but do you, Tricia, Belinda? Yeah. I'd be very worried if. I mean, I do see some kids look like adults, but no.
If any patients coming in for residential aged care facilities,
You do swap them?
into hospital events.
Yep.
Yep.
I think this will be a bit of a theme coming through the day, but molecular sequencing is very powerful, in some ways almost painfully too powerful, because we are now picking up a whole lot of community-based outbreaks happening in nursing homes in Metro North, and having some strong, robust discussions with public health about whose responsibility they are to follow up and investigate. But the reach is well beyond the hospitals. The bacteria don't know if they're in the hospital or not, so I'll give you a really good example of that later on today.
So, and that can be up to 100, around 100 into-hospital transfers a week that we in hospitals take. So it's a lot of patients, and that's overseas. People have come, had motorbike accidents in Bali, and plus the aged care facilities could just be somebody from Kimberley. So it's a range that we are supporting.
A little bit of a tangential question, maybe. I'm from Darwin. We're working on developing kind of a software tool, and I was really interested to see Cat High and also the Multipack tool. I'm just wondering how you use those in practice a little bit.
I could try. I don't have to need the link to log on.
Oh, I don't mean to do a live demonstration,
Yeah,
but just, I mean, for instance, is the Multipack, do you look at population or is it just
your
individual
hospital.
patient?
So it's actually quite a good system. It links in with the most up-to-date systems, OzLab and Hibiscus. But the actual Multipack's quite good, but OzLab, you don't know, but they're quite old. And it is very good because it gives you up-to-date information. So you can have whatever your HSS wants to switch on. So you can have tests of interest done in the hospital. You can have SIGOGs, anything, BSIs, occupational exposures, and it's constantly coming through from the lab up to date. As soon as it's confirmed in the lab or suspected, it pops up on our screen. So I can show you later if you like. I can work it out
I
again.
think the benefit for, so Multipack is the infection control surveillance system that's used within Queensland. It's used elsewhere as well. It's quite a few places now across the board.
South Australia?
Yeah, it's Australia, a few different spots. But essentially, you can set your own business rules.
Yeah.
So you can look at any patients, list out which pathology you want, which procedural work you want, and that all feeds into the system, and then it generates lists.
Yep.
So from a practice point, if you've got staff that are portfolio-based or dealing with a particular component of your program, so as Alison highlighted, you've got an occupational exposure list, you'll have an MRO list and other organisms of significance, and it pre-populates for you, and then it gives you the patient journey from a demographic perspective through the organisation. So you can look at what beds they're in, what wards they're in, and those types of things. So it's really operationalising some of the data, and it's automated, so therefore you don't have the risk, I suppose, of entering the data yourself and having data error and that sort of stuff. So that's very, very useful. And in terms of CAPA, we're only just starting to use it across the board, and I think Ryan's probably the best person, or Patrick, to speak to, or Caitlin, but having the little dots on the screen, because there's lots of dots on the screen, the one from the PA, and having a really quick, easy tool to say these all are the same. Genomically, they look exactly the same. And then at the bottom, and I don't know if that's in someone else's presentation later on today, but it gives you a little bit of a storyboard in terms of where the patient's been. And then that also can then lead, as Alison's highlighted, the importance is not just getting that genomic information, but using it and implementing it within your infection control program to improve those clinical practices that we do to minimise the spread of infection.
Used across Queensland.
And Marta uses that too.
Queensland Health.
And Marta.
The genomics, I'm sure, is in a large number of hospitals now. Data coming from everywhere.
It's quite a useful system because it's up to date, and you can set your business rules. So I don't care about some tests, but I do want to care about these specific tests of interest, like meningococcal or whatever, and I will just have them come up. So there's a lot of flexibility in that.
I think what I'd love to do is actually integrate Cat-High with Multipack.
Yeah.
That would be the ultimate merging. And I'm sure it could be done. It's just stitching the databases together. And Cat-High works best if you look at it on the screen, so you can sort of hover over a node, for instance, which would be a patient, and it'll give you a little bit of information about the organism, the patient. and then the metadata will come up below. So we often can't put it in our screenshots because they've got patient information there. And then you can click on a particular cluster and say, show me everything that's saved within 5 steps of that isolate that patient. And then it'll bring that up to you in sort of genomic way, and then you can put the metadata and see where you need to take things further. And Brian's working on things like having a time dimension to this, so you're not just looking at a static picture of everything, but actually how things evolve over time. You know, you could put this in as Chris was saying, the spatial dimension, so which, you know, where in the hospital this is happening. But it's, you know, it's a question of just putting this data into a format that people can understand. You don't necessarily need to know everything about genomics, but to use it in a practical way. But it's all a work in progress.
We'd love it if the Northern Territory came along with Multipack as well, because the more states that use it, there has been some national.
We don't have a statewide system.
There is talk about a national adoption of Multipack already, and that'd be great because it would be automatically enabled to benchmark across the country. Right? Because again, the bacteria.